This week on the BackTable Podcast.
So the advent of a bronchoscopic needle that can be delivered through a variety of different approaches, either through standard bronchoscopy, navigational, or even robotic bronchoscopy, is really revolutionary in our field. It is the first FDA-approved technology that we have for going to the periphery of the lung and for treating lung lesions. And we are truly learning in real time, and we're learning in concert with our colleagues in interventional radiology and thoracic radiology because their experience precedes ours, and because they also have the ability, have had the ability, to deliver a variety of different energies to peripheral malignant lesions in the lung.
Hello and welcome to BackTable. We have a very exciting show for you today. We're going to be talking about pulsed electrical fields. I have some amazing guests here that I plan to learn a lot from, and hopefully you can as well. First, we are introducing Dr. William Moore, Professor of Radiology, Vice Chair of Informatics, as well as the Section Chief of Thoracic Imaging, and my personal go-to for any lung cancer-related imaging. And we also have Dr. Daniel Sterman, Professor of the Department of Cardiothoracic Surgery, Director of Pulmonary Critical Care and Sleep Medicine, and the Director of our Pulmonary Oncology program, and an all-around great guy. So I am Ben Cooper. I am a radiation oncologist here at NYU and the Director of Proton Therapy. So to start things off, Bill, what is pulse electrical field ablation?
Yeah, so first off, thanks for having me on. Pulse electrical field is a newer technology. It kind of built off the backbone of electroporation. So back in the early parts of 2000s, there was this thing called a nanoknife, which was a multipolar system where you would put in a needle and have another needle directly parallel next to it. And then you would put anywhere between 3 to as many as 12 different needles in. What that would do is create an electrical current from one pole to the next, and a multitude of other cancers. I've used it myself in the lung. Pulsed electrical field is a departure from this concept of having two separate poles to having a monopolar system, which means a single needle goes in. And from that, you're actually able to create an electrical current that rapidly oscillates between the top and the bottom of the electrode, allowing there to be deposition of electrical energy into a tumor. It's a older technology that has now been advanced to allow for a slightly different way of delivering the energy. The huge benefit here compared to what we used to do back in the day is irreversible electroporation and the nanoknife device. If you were not perfectly parallel, it wouldn't work. So if you had anything more than a few degrees of separation between the two needles, they wouldn't actually generate electrical current, or you'd get disposition or poor conductivity between the poles. So that really was a major limitation. And as you can imagine, in a percutaneous approach, when you have a 20 centimeter needle, getting them exactly parallel is really, really hard. And this really takes that out. We really don't have to worry about that anymore. So that's where PEF started off as. That's kind of where we are right now with the device. There's two applicators right now. There's a percutaneous one. And then I'll actually hand it off to Dan to talk a little bit about the hardware that's available for endoluminal approaches.
So thank you very much, Ben, and thanks, Bill, for passing the topic on to me. I am an interventional pulmonologist, as well as being the division director. And one of the areas that interventional pulmonologists specialize in is the diagnosis and staging of lung cancer. But we have not had until really June of 2024, the ability to navigate out to the periphery of the lung and to be able to treat a peripheral malignant lesion in the lung. And so the advent of a bronchoscopic needle that can be delivered through a variety of different approaches, either through standard bronchoscopy, navigational, or even robotic bronchoscopy, is really revolutionary in our field. It is the first FDA-approved technology that we have for going to the periphery of the lung and for treating lung lesions. And it's been very revolutionary, and we are truly learning in real time. And we're learning in concert with our colleagues in interventional radiology and thoracic radiology, like Bill, because their experience precedes ours. And because they also have the ability, have had the ability, to deliver a variety of different energies to peripheral malignant lesions in the lung, from microwave to radiofrequency ablation to cryoablation and pulse electrical field. We don't have all those opportunities clinically available in the United States, although some of them are under investigation currently for treating peripheral lesions. And so, not that we don't already partner very closely with our thoracic radiology colleagues, but this is a new partnership in which we can, as we're developing our technologies, we're learning with them and really partnering and deciding which technology is best for which patient at which time.
Yeah, thank you, Dan. And I think that's a very important point that I think our listeners are probably more familiar potentially with microwave and cryo. And Bill, how would you say that this is different than some of these thermal techniques?
Yeah, so I've been doing ablation in the lung for about 20 years now. So we first started off, and I'll kind of give you the story of how ablation evolved. So we first started off with radiofrequency ablation. And the way RF works is you place an applicator into a lesion, and then you have ionic agitation, the surrounding tissue. So we actually would infuse saline to actually get some extra ions in there so you could actually get better agitation of the surrounding tissue. And what that would do is create a thermal injury. So we would get anywhere between 60 to 100 degrees centigrade ablation temperatures. The issue with radiofrequency, at least in the lung specifically, is the inhomogeneity of the deposition of the energy. So what that means is rather than having a perfectly round ablation zone, you would have these very odd shaped ablation zones based on these ideas of heat sinks. So a heat sink basically is any area in the lung that would pull away the heating energy. So blood vessels, chest wall, pleura, aorta, heart, those things pull away the energy, basically creating these relatively inhomogeneous intraparenchymal injuries. And what we started to notice is with RF, at least, our recurrence rates were pretty high. It is still, by the way, the mainstay of treatment in Europe because of the availability of the applicator. We then evolved in the early parts of the 2000s, 99, 2000 time period, to start doing some cryoablation in the lung. I actually started in 2005 with cryoablation. The benefit of cryo is a couple things. Rather than being a higher temperature, this is a lower temperature applicator. And what you do is basically use a Joule-Thomson effect, which is as you put any gas, with the exception of helium and hydrogen, we use argon for this particular device, you put a high pressure gas through a tube, and then at the end of the tube, you have an expansion chamber. And so it goes from very thin to much bigger. And what that does is creates a change in temperature. It's, again, the Joule-Thomson effect. And characteristically with argon, you get down to about minus 180 degrees centigrade. So a lethal temperature for sure. In addition to having that applicator in place, when you're doing your ablations, it does create a much more homogeneous area of ablation, number one. And number two, you can actually see your ablation very, very well with cryo. So your tumor gets very dark as you're doing the ablation under CT. So it does help you see what you've been doing. Both RF and microwave are heat-based, so they get higher. Cryo gets colder. Now, the microwave applicator, that came a little bit more recently. That's 06, 07, the first paper started coming out. And that uses basically a microwave antenna that's placed in to the lung. The benefit there is it is much more able to create a uniform destruction and uniform ablation compared to RF. And you can get similar temperatures. Because it's more uniform and more rounded, you get the ability to have a very, very robust ablation area. The downsides to that is it's a very uniform ablation, doesn't respect other tissues, and it will rip through pleura, it'll rip through bronchi. If you put it up against the heart, it will burn through the heart. So you have to be really, really thoughtful with your applications of it. Even to this day, the exact technique in the lung, the exact parameters to use is controversial. So it's one of those more controversial things. That's really the years of experience with both cryo, microwave, and RF. And overall, for small lesions, microwave is really most commonly used for very small lesions. And then, of course, I'm a big fan of cryo, and I use that for anything under about 2 to 3 centimeters. And I think it's important to hit a little bit about the size of these lesions. When we're doing these ablations, we have to think about how we're going to deliver the energy and how big our ablation zone is. So as we're starting to think about how we're delivering these energies, if I have a 6 centimeter lesion, I'm never going to get control over that with less than multiple probes, hours of work on trying to get control over this lesion. And the data that exists right now is with ablation, with our current techniques, microwave, cryo, and RF, under 2 centimeters size is really a critically important size, because at that size, we get 90+% control. Once we get to 3 centimeters in size, we go all the way down to 60% control. So it really is important to have an idea of what's plausible to do with these techniques that we have right now.
Yeah, if I may interject, Ben, I think that this is for an ablative approach, more commonly from an interventional radiology perspective, more recently from a bronchoscopic perspective, to try to be the equivalent of what you accomplish through stereotactic radiosurgery in terms of getting local control. But I think this is really important, and we'll talk probably more about this during the course of this podcast, which is there may be other goals, which may be right now in the research realm, that you have a larger lesion. Maybe Bill has a 6 centimeter lesion and he would not be able to get control of that lesion with a percutaneous approach. But there may be other options or the other interventions that can be done to that lesion that he can administer that may involve stimulating an immune response against the tumor. And I think that's really where there's a lot of work that remains to be done, but I think is really curious, which is what is the goal? Is the goal to completely control the local lesion, or is the goal to stimulate responses against tumor antigens that may synergize with systemic immunotherapy? And I think that's the intriguing aspect that we are just, I still think, in the early days of understanding.
Yeah, that's really interesting. If you could maybe speak a little more about that, why would pulse electrical fields be better than cryo or microwave for such a immune stimulatory effect?
A lot of this is hypothetical because they have not been compared, not in humans, head to head for that specific question. But there are unique aspects to cryoablation and pulse electrical field delivery in tumors that do not exist in microwave and in RFA. So as Bill said, microwave and RFA are heat-based technologies, and they reach very high temperatures. And one of the things they do, besides killing tumor cells, is denature the proteins within them and create these scars. And so these are not optimal conditions for presenting intact tumor antigens to dendritic cells within the tumor microenvironment to then take immature T cells, have them interact with these dendritic cells, and then create immune responses and working in concert with the draining lymph nodes. In fact, one of the things we don't know is whether, this may be true for SBRT as well, whether when we're ablating a lesion, definitively, whether we're ablating not just the tumor cells, but the other cells that might be in the microenvironment that you might rely on to generate an immune response. So cryoablation, for example, kills tumor cells in such a way that there is less denaturation of tumor antigen. And so you may have a more intact mechanism for presenting those antigens to dendritic cells, to immature T cells to be able to generate both local and systemic anti-tumor immune responses. And definitely in pulse electrical field works in a completely different mechanism through, again, this idea of altering the cell membrane and allowing this concept of electroporation to occur where there is no heat or cold-based, destruction of tissue, but rather a very different mechanism of cell death that almost certainly leaves tumor antigens intact to present to the immune system. In fact, one of the things that PEF does that may be unique is to generate this concept of tertiary lymphoid structures within the tumor microenvironment. And as we're learning from our immunology colleagues, these tertiary lymphoid structures within the tumor microenvironment are crucial for response to systemic immunotherapy and also have a significant prognostic effect on patients who have resected lung cancers, for example. Those who have more TLSs within the microenvironment will have less likelihood of recurrence after definitive surgical resection. So there's a lot to be learned, but I think that what's unique about cryo and PEF, in my estimation, is this at least theoretical, but increasingly evidence-based capacity to interact with the immune system for the benefit of the patient.
And I'm going to pop in, and I actually describe cryo and microwave as I'm going to destroy everything in the area, like without any real thought process. I'm going to just take everything out. That's my goal, is to destroy absolutely everything. And that is really tailored, in my mind, to a very local disease. So as Dr. Sterman was saying, a lot like the cases that you'll treat for SBRT, it's the concept of I'm going to destroy everything in the area and leave nothing left for any possible recurrence to occur. And that's kind of how I approach it. And as I'm doing the ablation, I'm looking for my zones to be completely included, and then a surrounding area of the lung in addition with the idea of having a margin around the tumor. And the margin for a primary lung is larger than a margin for a metastatic disease because they have a higher tendency to recur. PEF is completely different, a completely different energy. The applicator currently has such a small footprint. So as you're doing the ablation for cryo and microwave, I can create a 6 centimeter by 5 centimeter ablation zone with a 4 by 2 centimeter kill, as opposed to PEF, where I'm creating a 1 by 1 centimeter ablation zone. So very, very, very small. And because of the small nature of it, what Dr. Sterman was saying is, I think, absolutely correct. What is your goal of treatment? And as we started off with this device, I actually was not super excited about it because it's a device that creates a very small ablation zone. What's the point of that? But when I started to learn about the immunology behind it, what Dr. Sterman was just talking about, the TLSs, the creation of TLSs, the increase in the dendritic cells, there's now human data showing that there are IgG-specific antibodies circulating in patients at 30 days post-PEF ablation in the setting of colorectal cancer. So there is more and more data coming out that suggests that there is in fact, immunologic response here. And so I'm going to take a step back and talk about the mechanism a little bit about how PEF works, because we started off talking about heat and cold and just destruction. As you mentioned, there is an electrical current that is placed into the tumor. What happens is you destabilize the cell membranes. And by destabilizing the cell membranes, the way that works is you have too many positives on one side and too many negatives on the other side, and the sodium-potassium pump can't keep up anymore, and you start to denature the cell membrane, and you lose homeostasis, and everything starts to fall apart. But because it's not heat-based, you keep intact the cellular proteins, you keep intact the surface antigens, you keep intact the intracellular proteins, the DNA is released into the surrounding microenvironment. All these things are now being released into the surrounding microenvironment. And we know in humans and in mice, the human papers coming out, that there is increase in the dendritic cells in and around these tumors when they're resected at 3 weeks. We also know that there's an increase in, as Dr. Sterman started to mention, the immature to mature T cells, as well as these tertiary lymphoid structures. So you have activation of both your T cell mechanism as well as a B cell mechanism of immunity in these patients who are post-PEF. So because of the difference in the mechanistic delivery of energy, you're actually seeing an immunologic response, or you have the potential to see an immunologic response, as opposed to when I'm doing an ablation and destroying everything in the area, leaving left nothing in the surrounding microenvironment besides a lot of dead tissue.
Yeah, I think that's really interesting, because a lot of this mirrors what I've been sort of hearing and what I've been studying in the SBRT literature, where we're trying to also release tumor antigen, act as an in situ vaccine, and this whole abscopal effect that everybody's been chasing for quite some time. Do you have any data in lung cancer that this could potentially be beneficial in the metastatic setting?
Yeah, so when we first started with this device, there were two important things we needed to figure out. One, is it safe? Because there was safety data, it was approved as a 510K device, but we didn't really have large scale safety data. So a group of us got together that were doing some cases and looked at the safety profile. And in the lung specifically, the complication rates were very, very acceptable, very similar to biopsy. The serious complication rates were extremely low, again, very similar to biopsy, and far superior in general to most of the papers that are out there on cryo, microwave, and RFA. With some of those papers showing for RFA and microwave, 30% chest tube rates, like really, really high chest tube rates. This was much, much, much lower. So then after we got together and said, okay, it's at least safe, let's now look to see if there's any signal in any of our disease entities. So a couple of us got together. There were 3 institutions, Duke, NYU, and Cornell, where we said, let's take our stage 4 lung cancer patients who've failed prior therapies, because they are our sickest people. There are people who have had prior therapies who have now progressed through their first and second and third lines of chemotherapy. Apply PEF to them and then see how they do over time. This was done retrospectively. It was not a prospective study. We are trying to stand up a prospective study on exactly that question right now. And we were able to show that there was a doubling survival, not progression-free survival, but overall survival. So double the number of patients were alive at 1 year compared to a propensity matched cohort from NYU as well.
Yeah, I mean, that's certainly very compelling data that there has to be something going on there. And we definitely all look forward to some of the prospective trials.
Can I comment real quickly about that paper, this paper still is absolutely remarkable. And full disclosure, I'm also a co-author on the paper, but I'm looking at the data. I remember when Bill first sent me the data, and it was almost unbelievable. it's important to understand that there is a discrepancy between resist response and the overall survival data. And so this is very different, I think, than any other ablative technology in which you would hope to get resist responses, although this is a problem also in SBRT, right? Because you see a scar, and so how do you actually measure resist response? But if someone, certainly from the medical oncology community, were to look at this, they'd say, I don't understand how there's a benefit. You haven't had a resist response. But I think this speaks to the mechanism of action of pulse electrical field and the fact that the way it's probably working, and again, this needs to be studied prospectively, is in this setting, in the metastatic setting, in patients who have exhausted all other standard forms of therapy, it's working through an immunological mechanism, right? And so in these patients, creating a stalemate within the tumor by generating systemic anti-tumor responses, halting progression, a laudable goal, right? These patients want to live longer, and this intervention, as Bill said, is incredibly well tolerated. So in terms of the toxicities, they're low. And if there is indeed a survival benefit in this setting in patients refractory to other therapies, even more remarkable. So I think it's exciting, provocative, but needs to be proven in prospective randomized trials.
Yeah, and I think one of the big problems is we're so early. I've had this device for just over 2 years, 30 months, and you can barely get out a lot of data in that kind of time period, except for in extremely high rates of mortality disease entities. So, which is one of the reasons we really focus on the stage 4 disease. But to understand what this is going to do for a primary lung cancer is going to take years and years and years of data. So most of the papers that are out there, you look at a 3-year survival, but it takes 5 to 6 years to really have 3-year survival data because you have to let that data mature. So that's one of the bigger concerns that I have about, some of the papers that were pushed out super early. They just didn't have the tincture of time. And we do need to give the patients some time to mature. I have, however, seen some remarkable patients. So one of the actually first lung cancer patient I treated with this device had stage 4 lung cancer and multifocal disease all over his lung. He came back to the clinic on Tuesday, still alive 30 months after his initial procedure, which is unbelievable for a stage 4
Very impressive.
person.
Absolutely.
There's something going on here, more than just a nail kind of a hammer and nail kind of concept where I'm going to destroy something and move on. It's much more extensive than that.
And one of the things I'd love to discuss as a group amongst the three of us is just the idea, we kind of have a mini tumor board here today, is what we typically do on a Friday morning when we have our multidisciplinary tumor board, and it's radiation oncology, interventional pulmonary, radiology, thoracic surgery, pathology, et cetera. And we see these patients with multiple lesions. And I think what's fascinating is how we should be thinking about approaching, whether this is metastatic or the multifocal adenocarcinoma type patient, how we think about whether we should be using surgery, ablative technologies, or SBRT, or some combinations in this patient population. And I'd like to hear your thoughts, Ben, about how we should be doing this in a structured fashion as opposed to the ad hoc fashion that we do at Tumor Board on a Friday morning.
Yeah, so I do think this needs to be studied prospectively to try to get a sense of that. I was inspired by some of your early work dealing with this challenging patient population where we have a patient with 10, 15, 20 ground glass nodules, which are eventually going to probably progress, but you don't know which one. You don't know which one is the most serious, and you don't know how long until that progresses. And the work you did with the Imprint trial, trying to address this problem systemically, I think would be a good backbone to then build in possibly the addition of some local therapy. Dan, if you want to just talk about the Imprint trial, just so our listeners have a sense of what that was.
Sure. The Imprint lung trial was a trial led by Jay Zhang, a medical oncologist from MD Anderson, with 3 sites: University of Colorado, MD Anderson Cancer Center in Houston, and here NYU Langone Medical Center in New York City, and addressed this concept of patients who either presented with multiple ground glass nodules, which were of intermediate risk and not felt yet to be high enough risk for definitive intervention, or patients who have had prior lung cancer, stage 1 lung cancers resected, or definitively treated with SBRT, who have residual ground glass nodules also felt to be intermediate risk. These are patients for whom right now we ask Bill to just follow these patients with CT scans on a periodic basis. And it's just, we wait and we take almost a whack-a-mole approach, waiting for one of these to grow. And then we talk about surgery, SBRT, or bronchoscopic or percutaneous ablation. The Imprint lung trial was designed to try to be more proactive. The idea is, can we build upon some of the data from Jay Zhang and John Haymack's laboratory at MD Anderson, showing that there are immunological mechanisms that are active in these pre-malignant lesions in the lung, likely atypical adenomatous hyperplasia or adenocarcinoma in situ, that the administration of a checkpoint inhibitor, just 4 doses every 3 weeks, might impact the growth and even induce regression of some of these nodules. And so this was the first time, to my knowledge, that checkpoint inhibition had been used, I think, in any tumor in a cancer interception model, which is these are not patients with defined tumors. You're using immunotherapy to prevent tumors from developing in the first place. So it was a beautifully conducted trial, reached its full accrual fairly easily because there are a lot of these patients out there for whom we really don't have a lot to do. Safe. We've had some immune-related adverse events, as you could imagine, but in general, very safe and well-tolerated. And we're tabulating the data now in terms of what the response rates are. We'll be publishing soon. But looking towards the next phase, and again, interested in working with Bill and with you and how we can do this even better in the future.
Yeah, so I think I'd like to build off a backbone for either the metastatic setting or in that cancer interception setting. We've heard a lot today about how PEF potentially is stimulating the immune system. We have some data that SBRT does that as well. I recently published a paper looking at a STING agonist combined with checkpoint inhibition with radiation before to try to give a little boost in patients that had already failed checkpoint inhibitors. And we did see some peripheral blood changes and had some responses. I have a patient that's been on that STING agonist for over 2 years now, still without any progression of disease. So I think we could do something where we add SBRT and or PEF. I think you could study them head to head, or even a 3-way trial with just the checkpoint inhibitor to see what actually is doing, just to see which cohort performs best. I think that would be a very interesting trial, looking at peripheral blood correlates as well.
Ben, can I ask you a question about that? So is SBRT, should we be thinking about it as non-radiation oncologists as binary, either you give it or you don't, or is it tunable? So is this potential immune interaction dose dependent on the SBRT side?
Yeah, so there's been a lot of preclinical data on this. Dr. Silvia Fermenti up the street at Cornell has looked at doing a large dose of radiation, like 20 gray in 1 fraction versus 8 gray times 3 fractions, and looking at the CGAS STING pathway. There did seem to be a benefit to the lower fractionated dose. And we have been talking about what is the goal of what we're doing. So when I'm treating a stage 1 lung cancer, we're treating doses north of 50 gray. So those are truly ablative doses, possibly working on actually destroying the surrounding cells to the ceramide pathway and other mechanisms of action. Whereas whenever you want an immune stimulatory response, most people are testing lower doses because you don't necessarily want to destroy everything, or else you won't be able to traffic the dendritic cells and really stimulate that immune response. So I don't think we know exactly what the right answer is. Probably the most commonly studied and what I used in my study and others have used is 8 gray times 3.
Now, Ben, are you focusing also on alternates to SBRT and looking at highly conformal lower doses in addition to or instead of SBRT to try to get an immune stimulatory response as well?
Well, so what's really interesting, and there was a trial proposed to CTEP, I don't believe it ever was able to be completed, where they looked at actually going down to 0.5 gray. So this extremely low dose as potentially being immune stimulatory in that setting versus 8 gray times 3. I thought that would have been a very interesting trial to do. It's a hard trial to fund because there's no radiation device manufacturers that really care too much. They're not going to sell more machines based on how that trial resulted. So while it is interesting, I don't think that was ever conducted, and I don't think we really know the answer.
Ben, does it matter whether the dose is delivered as electrons or photons or protons? I'm sorry.
We don't have any specific data on that I know of that really shows one is better than the other. One thing that has been looked at and there was some excitement about is something called flash therapy, which is radiation delivered at an extremely high dose rate that somehow seems to not really disturb the surrounding tissue as much. That really was not possible with photons or X-rays because with our current radiation technology, but with pencil beam scanning protons, they are able to achieve these very high dose rates with the IVA platform, and that is being studied through a FLASH consortium right now. So Dan, Bill told us about his patient. I talked about a patient I had. Have you had any patients where you've done PEF and you really felt like you had a great response?
So there are 2 patients that I would want to highlight. One is a patient that you and I shared, Ben, an elderly gentleman, well into his high 80s with multiple medical issues, who was diagnosed with locally advanced non-small cell lung cancer. Actually, it had one resected, the other you treated with SBRT. And we then found through a scan, probably read by Bill, that there was a new lesion in the left upper lobe, because he'd had a segment of the left upper lobe resected, and this was the residual aspect of the left upper lobe. And so we asked our colleague, Dr. Jimmy Bessick, our section chief of interventional pulmonology, to go and biopsy these areas. We found that he actually had a recurrence in the SBRT-treated lesion in the left lower lobe. And in the left upper lobe, the nodule that we thought was either a new primary or metastatic focus of his non-small cell was a small cell carcinoma. And what's interesting is that at the time, I had asked Jamie to do a PEF ablation bronchoscopically at the same time of the diagnostic and staging procedure, which is one of the great aspects of both percutaneous and bronchoscopic, is that this can be incorporated into a standard of care diagnostic procedure. And so she did this before we even had the pathology back, showing that it was small cell. And this patient then decided, with the diagnosis of a limited stage small cell, he was not a candidate for surgery, and it did not want chemotherapy, immunotherapy, or an antibody drug conjugate, and so went to you for SBRT. And what's really remarkable is this is now a year, and there's no evidence of disease whatsoever of the small cell. We also, in this patient, went back and retreated the left lower lobe lesion with a local recurrence after SBRT with PEF, and he's had no evidence of recurrence locally either. So right now, I can't say whether he's NED, because he still has radiographic abnormalities, but there's been no evidence of the small cell carcinoma and no evidence of progression of his left lower lobe lesion. So this raises two intriguing areas for us, which is there a role of PEF in small cell carcinoma, which is an area now that we know is immunologically active because checkpoint inhibition is now part of the treatment of early and late stage small cell. And the other is the intriguing combination of SBRT and PEF. And can they be not just additive, but can they be synergistic?
Yeah, there's a bunch of things that are important there. I've had a couple of small cell patients, and similarly, they do remarkably well post-PEF, almost unbelievably well post-PEF. It's one of those diseases that the survival rate's in the single digits. I think that's a fascinating area. And the other area that's interesting is local treatment failures from whatever. SBRT has very, very few local treatment failures, but this particular device, the amount of hemorrhage that we see post PEF is so low that it actually gives you the opportunity to go into these post-ablation zones. With cryo or microwave, and really microwave you shouldn't even do in a post-SBRT zone. The rate of hemorrhage is just massive. So it does give us an opportunity to, in areas that were treated that do fail, again, not super common, but when it does happen, it gives us an opportunity. The third thing that I wanted to touch base on is what Dan was talking about in terms of post-imaging for these patients. So these are some of the most complicated things that I do on a regular basis. So between SBRT, cryo, microwave, and PEF. Cryo, microwave, easy. I love it. It's a piece of cake. It's a scar or it's not. And if it's not a scar and it's getting bigger, it's recurrence. Really, really easy. With SBRT, it can be extremely challenging to really understand what we're looking at. And we can end up really spending a lot of time trying to decide whether something has gotten bigger. If it has gotten bigger, is it inflammatory? And there's some rules that we use. So if you look at the data that's out there, you really shouldn't be calling recurrence on imaging post-SBRT for a year. Unfortunately, that means you wait an entire year before you can call something that may be a local recurrence. But because of the consolidative or inflammatory patterns that happen after SBRT, it can be really challenging to differentiate local recurrence from a just normal post-SBRT zone. PEF is also similar in this way. We don't really understand the post-imaging aspects of PEF. And what we seem to see is when you do a PEF, the lesion has a tendency to kind of just stay there. It doesn't really change a whole lot. It doesn't really go away like you expect with the microwave or cryos. It doesn't become a scar because the mechanism of action isn't to create a destroyed scar. I kind of describe the idea behind the destruction that occurs with cryo and microwave as you cut yourself with a knife. The body's job is to go in there, clean the area up, stitch it back together, and make it look like there's nothing ever happened. Or leave a little scar, right? Makes sense. That's the same kind of concept as I have for microwave and cryo. PEF is totally different. It does not create a response like that. It is not intended to stitch you up and create a scar. If anything, it should create a keloid in that concept. It should create an immunologic response. So if you kind of think of it like that, it makes a lot more sense. So the post-imaging can be really challenging to understand. And a plea to my clinical colleagues, please let us know what you did. It can be incredibly hard to understand what's going on in these patients. I've had my post-ablation zones called for my colleagues abscesses when they're not, they're just post-ablation zones. I've had everything you can imagine it's been called. So it's really, really challenging. And I'm telling them it's a post-ablation zone, they're still getting it wrong. So it's really, really, really challenging some of these things. So as much information as we can get, the better.
Bill and Ben, if I may add, this is incredibly intriguing, which means that we need to be using new imaging technologies, likely using AI, to try to do a better assessment of these nodules. So Bill referenced his paper that came out last May about this propensity matched cohort of patients with stage 4 lung cancer treated with PEF with significant survival. I'm really interested in working with Bill and some other research colleagues in going back and analyzing those CT scans. And we should know who are the long-term survivors and who are not, and see if there are imaging correlates of that can only be determined by AI evaluation of those original lesions, because this would then tell us whether patients may benefit or not from PEF. If we have a radiologic signal through AI in terms of who is the best, has the best, tumor microenvironment, which essentially was what we're going to be asking that question to respond, then we'll know a priori about what treatment they should be getting. So I think this is really intriguing. And I know in SBRT, you're probably looking at some of the same questions.
Absolutely. Yeah. I think harnessing AI to help us interpret these CT scans is going to be incredibly important, because I would say that's half the cases I bring to tumor board. We're really just trying to figure out what's going on. And you end up getting PET scans and adding cost to the system, adding radiation to the patient, all these types of things. I do want to change gears a little bit right now, because a lot of the listeners are proceduralists that work out in the community. And you did mention about this being a smaller ablation zone. So I'd like to talk about procedure time with both you, Bill, and Dan, and how that compares to some other therapies that you do either intralesionally, Dan, and some of the things you offer are percutaneously, Bill.
Why don't you get started, Dan?
Sure. So right now, as I mentioned, we have a relatively limited armamentarium for what we can do out in the periphery of the lung. In the central airways, there's a lot that interventional pulmonologists can do. We have a number of different ablative technologies that are approved, from Nd:YAG laser to PDT to cryoablation. All of these are approved for use through a flexible or rigid bronchoscope to treat, central airway obstruction, for example. But in the periphery of the lung, very little. So right now we're limited to pulse electrical field delivery, which gives us a small ablation zone, as Bill described, but also requires sometimes ablation times of upwards of an hour to treat a peripheral lesion, which is 3 centimeters in diameter, between 2 and 3 centimeters in diameter. It's a long time. And the other thing I should say is that using endobronchial ultrasound, we can treat lymph nodes. And there's some really intriguing data that treatment of tumors that are in lymph nodes in the mediastinum or hilum might be very effective. And that's somewhat quicker, but still, if the nodes are large, the ablation times are long. We're hopeful that there will be modifications to the device and to the generator that will allow for more energy delivery in shorter periods of time, and Bill can elaborate certainly on that.
Yeah, so I'll go from longest to shortest in terms of the ablations. So PEF by far is the longest because of the extremely small ablation zone. So I did a case yesterday. I did 8 activations, so that's 40 minutes of ablation. Bare minimum. That's assuming that I have perfect placement of the needle each and every time, which is impossible. So it does take longer than that, but it's at least 40 minutes of active ablation. Each of the ablations, the way that the system works is to create the 1.3 by 1 centimeter ablation zone. You have to allow for 100 activations, and that, based on a heart rate of around 60 to 70, takes about 5 minutes. So if you're doing 8 activations, it's 8 times 5, 40 minutes. The size of the ablation zone that you are planning, basically what I do is I go in, I measure the volume of the lesion in assuming an elliptical volume, come up with how many ablations I would have to do to get 100% or more control over the lesion. So that's kind of how I decide what I'm doing. Number 2 is actually cryo. To do a single cryo cycle, I used a modified triple freeze, which is about 28 minutes of freezing. So, if you have only 3 or 4 activations, that's a lot quicker for PEF compared to cryo, but cryo creates a 6x4 characteristically ablation zone, and then a kill zone that's a bit smaller, but still about 28 minutes. Microwave is the fastest by far, where you can get anywhere between 8 to 10, maybe 12 minutes to create a very large ablation zone. The biggest issue there is you worry about the ablation zone running away from you. As you start to deposit this heat, it gets bigger and bigger and bigger really rapidly. And so you want to really control those ablation zones. So the timing for PEF is similar, but longer depending on how big your target ablation is.
So Ben, it's interesting that we're studying bronchoscopic delivery of therapeutic molecules into tumors and lymph nodes. And obviously this takes a fraction of the time because we're literally taking a syringe or a syringe pump and injecting an immunotherapeutic or a chemotherapeutic agent directly into these lesions. And that takes a matter of, seconds to a minute. So not that those are compared, we're in the experimental realm with intratumoral therapeutic delivery as opposed to these energy deliveries. And there may well be synergies between the two, but the time differential right now is substantial.
Yeah, and we're all working together on this trial in patients with locally advanced lung cancer where we're actually injecting hafnium, which is a nanoparticle that's high density, high electron load that can help radiosensitize the tumor. And in that trial, your team is actually injecting directly into the tumor and the lymph nodes. How does that compare time-wise if it's a larger tumor to try to spread the hafnium around the tumor?
Yeah, I mean, part of it is that the trial asks us to admix contrast material so that we can visualize we have a mobile cone beam CT within our interventional pulmonary operating room at NYU. So we have to visualize the fact that we are localizing the hafnium within where we want it to be. And we want to make sure also that it's not spilling out elsewhere. And that's really important. So, but still, I think that to deliver to the various areas, again, in the trial that you're leading at NYU, Ben, we're asked to try to get as many of the areas of tumor and lymph node involvement involved as possible. So not just one site. So probably somewhere between 10 and 20 minutes for delivery of the hafnium would probably be average, not counting the actual navigation to the site before and afterwards.
So now I'd like to, channel my inner Pat McAfee here. So I'm from Pittsburgh, diehard Steelers fan. And I don't know if anybody heard the news about TJ Watt over the last week, but he was with his therapist and the therapist decided they wanted to do Bill Moore's job. So he was getting dry needling and they entered the thoracic cavity and he had a pneumothorax. So how did pneumothorax rates compare with this compared to other ablative technologies?
So it's much lower than trainers doing it. No, So in terms of the different devices, so if you look at the papers that are out there on microwave cryo, they're all about the same with somewhere around a 20 to 40% pneumothorax rate requiring chest tubes. Some of them are as low as 10%, but for sure, the rate of pneumothoraces are larger. You have to remember that these applicators for microwave and for cryo are quite large, and they're cutting tip needles. So for the cryo device that I use, it's a 14 gauge cutting tip needle. It's quite substantial. So the fact that we only get 10%, 20% pneumothorax rate is actually pretty good. For the PEF device in the trial that we put together with multiple different users from multiple different locations with extremely variable amounts of experience, the chest tube rate was 10%, which is really good for a multi-center trial. And as people become more and more comfortable with it, that has come way, way down to around 4 to 5%. I quote about a 2% rate. And for biopsies percutaneously for us, it's around 1% to 2%. And then for Dan's stuff, completely different. And I'll let Dan talk about it.
Yeah, we win in this area, right? We can't yet compare outcomes, but in terms of pneumothorax rate, the bronchoscopic approaches, especially robotic bronchoscopy with cone beam CT guidance, especially if we're selective and not biopsying and treating immediately subpleural lesions, it's the pneumothorax rate requiring chest tube is about 0.5%. So there's no question that we win in this area.
Very good. Very good. Well, I think we're almost out of time. Is there anything either of you would like to add that you think the viewers really should know or some take-home points about pulse electrical field ablation and where we might be going in the future?
Yeah, so I'll start in terms of the proceduralists who are involved. I think it's really, really critically important to work within your institution with a team of people who actually know the cancer you're dealing with backwards, forwards, left, and right. I have the great benefit of, I'm not an immunologist, I'm not, but I have an unbelievable number of people behind us who can help us understand the immunology behind it, help us really pick patients appropriately. Really rely on your pulmonologists, your oncologists. If you are a pulmonologist and you're listening to this, rely on your oncologists and your surgeons to really help you select patients appropriately. And when we're all doing it together, it's amazing. You can get a ton of patients for everybody really quickly.
I would just add that even though this technology has a 510(k) approval for soft tissue ablation and the variety of organs, including the lung, it's still important to study, right? So I think that it's safe, and we can do it percutaneously or bronchoscopically safely, and early data is provocative, but we need to study this in a variety of settings. We need to study it in locally advanced disease, in combination with chemoradiotherapy, potentially in stage 3 disease, potentially in small cell. And it takes a lot of time, effort, and frankly, money to be able to do these studies, but it's incredibly important. And at minimum, and Bill was instrumental in doing this together with a company that provides this technology, have a registry in which we can collect these cases and see and learn from what we're doing, even for clinically indicated cases. Because if we just all do it on our own and try to figure it out without systematically understanding it, it's going to be to our deficit. And lastly, I'll just say, it's really important to get biological specimens before and afterwards, if you can, as part of prospective studies, to learn what's going on in the peripheral blood in response to PEF ablation, as well as in the tumor microenvironment. And I would argue we're really interested in our group here at NYU in what's going on in the draining lymph node proximal to the lesion in the lung parenchyma. And so if we can learn what's going on in the lung, in the lymph node, and the peripheral blood in response, we're going to learn so much about who's going to benefit from this.
Yeah, absolutely. I believe that's the Propel prospective registry that you were mentioning, that they're hoping to have 50 sites and 1,000 patients. So
Correct.
Hopefully there'll be a wealth of data that we can learn from there. And, hopefully we can help more patients with all of these findings.
And one of the smart things they're doing, they're actually collecting the images as well. So it's a robust database. So they've done the right thing there.
Well, I'd like to thank you both for taking the time and speaking with me, and thank the listeners. I know I've learned a lot. Hopefully some of our listeners have as well. And I hope you have a great holiday season.
Thanks, Ben. Thanks for including us.
Thank you so much for joining us on BackTable Tumor Board. If you haven't already, be sure to follow and subscribe, rate the show 5 stars, and share with a friend. If you have any questions or comments, direct message us at _BackTable ONC. That's _BackTable ONC on Instagram, X, Blue Sky, YouTube, or LinkedIn.
Our production team is led by Kieran Gannon,
Aaron Bowles,
Gabe Legrazio,
Josh Spencer, and Jaden White.
design and digital marketing led by Brian Schmitz.
Social media and PR by Donato Cavuto.
Administrative support provided by Judy Dela Cruz.
Music by Aaron Bowles.
See you next time.